Hey everyone, this is Dr. Medicine Alex, and in today's video we'll be discussing about systemic sclerosis. So it is an autoimmune disorder that is characterized by loss of skin elasticity along with tightness of the skin occurring as a result of thickening and hardening of the skin. Coming to epidemiology, females are more commonly affected than males and the peak age of onset is in the 4th decade. Coming to predisposing factors, genetic factors, they play an important role with certain HLA factors being involved. Then coming to the environmental factors, smoking because it causes vasculopathy also triggers systemic sclerosis. Occupational exposure to silica, polyvinyl chloride, certain organic solvents and synthetic adhesives is a very important factor. Infections, especially viral infections such as cytomegalovirus infection, and certain drugs such as bleomycin and pentazocine all act as triggers and predisposing factors for systemic sclerosis. Coming to pathogenesis, so there are mainly 4 steps involved. So first is vasculopathy, which occurs because of the aforementioned triggers, and these cause endothelial cell injury leading to their activation, and these activated endothelial cells, they cause inflammation, which is the second step, where Th2 predominant type of inflammatory cells are seen. These inflammatory cells, they cause release of profibrotic cytokines leading to a third step, that is fibrosis. These profibrotic cytokines, they cause increased collagen deposition, they cause release of fibroblasts, which cause further collagen deposition in the skin and viscera. And the fourth step is autoimmunity, where various types of innate and adaptive immune responses occur, and followed by there is going to be autoimmune response. Coming to there's a classification of systemic sclerosis on the basis of skin sclerosis, where it can be limited cutaneous scleroderma systemic sclerosis type, where only the fingers and the neck and the face are involved, that is trunk is spared. And then there's diffuse cutaneous scleroderma, where there is both extremity and the truncal involvement. And then there's intermediate cutaneous scleroderma, where the upper and lower limbs, neck and face are involved, but there is no truncal involvement. And there's something called as cyni scleroderma, where only the organ involvement is present and there is no cutaneous features. And there's something called as overlap syndrome, where it overlaps with other kinds of autoimmune diseases. And there's paraneoplastic scleroderma, where it occurs as a late onset of diffuse scleroderma because of certain neoplasms or malignancies of the lungs and the skin and the breast. And there's also crest syndrome, which is very important, which refers to calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly and telangiectasias. So these are various kinds of features, various kinds of ways systemic sclerosis has been classified. So the presentation can be either as Raynaud's phenomenon, where the patient can present with Raynaud's phenomenon, and it is most commonly seen in the cold areas, or in certain cases it can present with gastroesophageal reflux disease or as dysphagia, and in some cases it can present as swelling or discomfort in the extremities. And these 3 are usually the presentation features. Coming to clinical features, so I have divided them into cutaneous and systemic features. So in skin, the first and foremost feature is going to be sclerosis, which usually develops first on the fingers and the hands. And there's going to be non-pitting edema and puffiness of the fingers, hands and face, and it is often the earliest cutaneous manifestation. Following this edema, there's going to be induration and thickening, and the skin gets fixed to the deeper structures on the fingers, leading to something called as sclerodactyly. Now this skin sclerosis, it leads to progressive loss of skin appendages. As a result, there's going to be reduced hair growth and reduced sweating, and along with that, because of sclerodactyly, there's going to be joint contractures. Now Raynaud's phenomenon, as we have discussed, is an important presenting feature, and also it can lead to pitted digital scars and tapering of the fingers and digital ulcers, and even certain trophic changes of the finger pulps. Then pruritus, it is seen in about 40% of the patients, and it is usually seen in the early or active stage of the disease. Telangiectasias, they are seen along with the face on the upper trunk and limbs. And then the face, it has characteristic features where it is mask-like facies, something called as mask-like facies, because the face becomes, because of the sclerosis and thickening, it becomes waxy, and there is reduced wrinkling, and the nose is beak-shaped, and there is radial furrowing of the perioral skin, and because of that sclerosis there is also reduced oral aperture, and even mat-like telangiectasias are seen on the face. Coming to the pigmentary changes, there is something called as leukoderma or scleroderma, where there are localized areas of depigmentation with sparing of the perifollicular skin, and this leads to salt and pepper sign. And there can also be diffuse hyperpigmentation with accentuation in the sun exposed areas, and there can be acanthosis nigricans like pigmentation or Addisonian pigmentation as well. Coming to calcinosis cutis, it is a type of limited systemic sclerosis feature, and in that there's going to be what we call as dystrophic calcification on the extremities and near the joints, and even in the pressure points. Next, coming to leg ulcers, they are also seen in about 40% of the patients, and they heal very poorly. Then livedo reticularis, and there is something called a scleroderma neck sign, where there is a palpable tight band over the platysma in the hyperextended neck. It also happens as a result of that sclerosis. And the round finger pad sign, where the peaked contour of the finger pads is lost and it is replaced with a hemisphere like fingertip contour, and it is very apparent in the ring fingers. Now coming to systemic features, first off, the constitutional symptoms, fatigue and weight loss are common, and this weight loss, it can be due to reduced appetite or because there is a difficulty in eating and dysphagia. Then coming to GI manifestations, they are seen in about 90% of the patients, and they result because of the fibrosis, and they can affect any site of GIT, and because of the esophagus, because of involvement of the esophagus, it can lead to esophageal dysmotility and dysphagia and GERD, and esophageal involvement is the most common. Then in stomach, there is decreased acid secretion and also reduced gastric emptying because the motility is reduced as a result of visceral sclerosis as well. And there's something called as watermelon stomach, where there's linear vascular malformations are seen along the antrum of the stomach, and there's also iron deficiency anemia because of this watermelon stomach. Then involvement of the small bowel leads to bloating, malabsorption and malodorous diarrhea, and also episodes of pseudo obstruction. And if sigmoid colon and rectum are involved, there is constipation and overflow incontinence. Liver, it is usually normal, but in certain cases it can present as autoimmune hepatitis. Coming to joint involvement, arthritis is something that is most common, and it can be oligoarticular or polyarticular, and the fingers, wrists and ankles are predominantly involved, and joint contractures also occur, leading to limitation of the movement. Next, coming to tendon friction rubs, it is where there is thickening of the tendons because of sclerosis, and when they move they cause coarse crackling or crepitus like sound. Then muscle involvement, it is a common feature, and it can be in the form of myopathy leading to weakness, and sometimes even the myopathy can be inflammatory, and there can be changes on the electromyogram. Then renal involvement, it can be because of progressive fibrosis or because of the vasculopathy or because of the treatment that we are giving, especially steroids. They can be nephrotoxic, or because of the presence of autoantibodies causing glomerulonephritis. Scleroderma renal crisis is important complication where there is going to be severe hypertension, increased renin levels, thrombotic angiopathy and progressive renal failure. Then pulmonary manifestations, they occur in the form of fibrosis, interstitial lung disease and pulmonary arterial hypertension. ILD and PAH are the most common cause of death in systemic sclerosis. And they can lead to dry cough, breathlessness, palpitations, peripheral edema and syncope. Coming to cardiac manifestations, it is if cardiac manifestations occur, then they are a poor prognostic factor, and it can be in the form of myopathy or arrhythmias and even pericarditis as well. Coming to dental anomalies, there is widening of the periodontal space and also thickening of the periodontal membrane. Coming to investigations, bedside investigations would be to test for Raynaud's phenomenon in the form of provocation test or even nail fold test or cold challenge test. And then nail fold capillaroscopy, which is a very important investigation in systemic sclerosis. It shows disorganization of the nail fold capillaries. There is giant capillary loops, vascular dropouts, hemorrhages and angiogenesis, and even some avascular areas. Coming to skin thickness measurement, it can be done using various instruments such as durometer, cutometer, 20 mHz USG, or optical coherence tomography. And then coming to skin biopsy, the epidermis is thinned out, there is reduced appendages, and there is lymphocytic infiltrate and fibrosis in the dermis. Coming to serology, doing anti-nuclear antibody testing where anti-SCL70 or the anti-topoisomerase antibodies positive in diffuse systemic sclerosis, anti-centromere antibodies positive in limited systemic sclerosis, then anti-RNAP3 is seen in scleroderma, renal crisis, and paraneoplastic scleroderma, anti-U1 RNP in mixed connective tissue disease, and anti-PMSCL in myositis overlap. Next, GI investigations for the esophagus. For the sake of esophagus, we can go for manometry, endoscopy, or barium swallow. For small bowel, we can do hydrogen breath tests or even plain radiography like X-rays and colonoscopy and sigmoidoscopy. And for large bowel, we can go for barium enema, CT, or X-ray. For lung, pulmonary function tests, FVC, DLC, or ratio, HRCT for interstitial lung disease can be done. For CVS, echo, ECG, right heart catheterization for the sake of pulmonary arterial hypertension, even cardiac MRI. And for renal function tests, urine examination, monitoring of BP to detect any renal artery stenosis, and even ultrasound and glomerular filtration rate can be done. Coming to management, for Raynaud's phenomenon digital ulcers, we can go for calcium channel blockers. They are first line treatment. In that, nifedipine is tried. Then phosphodiesterase 5 inhibitors such as sildenafil and taldefil. And if there is any impending ischemia, risk of ischemia, then we can go for IV iloprost. Endothelin receptor antagonists such as bosentan can be tried in severe cases where there is impending ischemia and or ulcers. And other drugs that have been used for this purpose are losartan, fluoxetine, and topical nitroglycerin. For skin manifestations, methotrexate with PUVA form the first line of treatment for mild and early cases. And if the cases are moderately severe, then we have to go for mycophenolate mofetil. And if it is not responsive, then we can go for cyclophosphamide. Hematopoietic stem cell transplantation can be given when they can be done when this severely rapid progressive case with organ dysfunction. And obviously we need to put the patient on sun protection and manage the pruritus with emollients and antihistamines. And then for pulmonary arterial hypertension, endothelin receptor antagonists with or without PDE5 inhibitors because they are vasodilators. Then epoprostenol, and if the interstitial lung disease is present, then mycophenolate mofetil and cyclophosphamide are to be given. For GIT, if there is any GERT, proton pump inhibitors, and if there is decreased motility, then prokinetic drugs. And if there is any bacterial overgrowth that is symptomatic, then we have to go for rotational antibiotics. For the management of joint manifestations, methotrexate, low-dose steroids, and hydroxychloroquine as a third-line agent can be tried. And if there are any renal manifestations, angiotensin ACEI inhibitors, angiotensin converting enzyme inhibitors are to be tried. And we have to be very careful while prescribing the patient on steroids because they can predispose to scleroderma renal crisis.